Good afternoon. First of the thanks to the organizer, Mr. Akash Singh ji, Prakash Jotwani sir, Kuldeep ji, and all the organizer of the RSD Gujarat chapter. Just I am a last speaker of the before the lunch, and topic was given the how to make up the hypoglycemia awareness. What is a hypoglycemia? The low blood sugar causing the some of the asymptomatic and symptomatically neuroglycemic, neurogenic and autonomic dysfunction, and which are relieved by the raise the blood sugars whatever. What will be clinical definition of the hypoglycemia? Mild. Some of the patients coming with the 110, 120 of the blood sugar, but it is a mild hypoglycemia. Most of the patient is getting the self-treated. Severe require the some of the recovery. Biochemical, how to definitions of the low plasma glucose. If I am talking with the 3.9 millimoles, if the blood sugar is a 70 milligram deciliter, if the blood sugar is a 3.9 millimoles, is a less than 70, is according to ADA and European criteria. And what about the our treated with the patient is on the insulin with the OHA, if the blood sugar is a less than 72 milligram deciliter, is a considered as a hypoglycemia. These are some of the hypoglycemia. What is a common cause of the hypoglycemia? General cause of the inadequate, delayed, miss the meals once. Generally, we should take of the breakfast, lunch, dinner, the two of the light meals, exercise. We are going to the too much of the exercise can cause the energy expenses. Too much insulin with the OAD, with the drugs and some of the excess alcohol. These are a common cause of the factor of the hypoglycemia. And the risk factor of the severe hypoglycemia is the duration of the insulin treatment, very tight control of the HbA1c. Some of the young patient we are keeping of the HbA1c 6.5 to 7, but patient is coming with the elderly, we should keep the less acidic. We are keeping the HbA1c 7.5, 8, lack of the sleep hygiene should be good. History of the previous hypoglycemia and a renal insufficiency with the most of the diabetic patient, they are having the CKD grade 1 and grade 2, and all the diabetic patient we are getting the urine for ACR of the must of the hypoglycemia is inconstitute reported defined. Report and symptoms by the patient with the diabetes varies. Inter-individual variation of the symptom threshold. Most common cause of the hypoglycemia are not always first to the report. Patient is coming 170 is just of the unawareness of the asymptomatically unrecognized episode can be missed. Especially of the nocturnal hypoglycemia is common in either type 1 or type 2 diabetes of this particular. Hypoglycemia episode often unrecognized by the patients. Hypoglycemia confirmed by the only CGM, all the type 1, yeah, type 2, yeah, brittle diabetes, and I'm going to advise they should put on the CGM. 63% of the patient type 1 diabetes and 47% of type 2 diabetes with the OAD, with the multiple drugs, with the basal insulin, and most of the hypoglycemia we are going to find 74% of the hypoglycemia occur in particular the night in between the 3 to 4 a.m. So impaired awareness of the hypoglycemia. How to make up the awareness of the natural history when patient with the normal awareness, identification, onset, hypoglycemia, autonomic and neuroglycemic symptoms equal to represent symptoms profile change gradual over the time, number intense of the autonomic decline, and neuroglycemic symptoms become the prominent, and patient with experience with the variable partial impairment of the hypoglycemia awareness. What is how to make up the impaired hypoglycemia? Affect the 20 to 25% of the type 1 diabetes. They are treated less than the 10% of the insulin treated over type 2 diabetes. Risk of the severe hypoglycemia 3 to 6 times more having this particular spectrum of the hypoglycemia severity may be reversible. No international of the guidelines of the definition, but in particular in type 1 diabetes out of 4, one person is having the hypoglycemia, and in type 2 diabetes out of the 10, one person is having some of the hypoglycemia of the. So what is a recurrent hypoglycemia? Is a diabetes with a mechanism of the the acute hypoglycemia. Acute means blood sugar is a less than 50 milligram deciliter of the absent or blunt the region of the cerebral blood flow at a level of the thalamus, hypothalamus of this particular. So EAI means impair the awareness of the hypoglycemia. So what is impair the awareness of the hypoglycemia? You can see if the blood sugar is a less than 70 milligram deciliter, our counter hormones are going to increase. But what glucagon and cortisol hormones are going to increase. If the symptoms, blood sugar is less than 755, is a patient is either autonomic dysfunction and neuroglycemic panic in between the 3 to 3.2 to 2.8 millimoles. If the blood sugar is less than 40, they are going to landed with some of the coma of this particular, these are some of the definitions. So glycemic threshold was modified in the impair the awareness of the hypoglycemia. You can see of the recurrent hypoglycemia with the antecedent hypoglycemia and strictly of the tight control of the, what is a consecutive sequelae of the hypoglycemia? Person is coming with the heat, with the blood sugar is less than 170, acute symptoms, upper motor neuron, mood change, and work performance, driving, social activity, sport, travelings, and some of the other morbidity, acute events. Long term, reduce the quality of the life, fear of the hypoglycemia, weight gain, employment, driving, personal relationship, worsening of the diabetic and the other the vascular complication and chronic symptoms of the. In type 1 diabetes with the recurrent hypoglycemia and diabetic, what about the sequelae of the? You can see of the normal awareness of the hypoglycemia in type 1 diabetes. What you can see of the type 1 diabetes of the 6 times more common in hypoglycemia, and in type 2 diabetes with the 17 times more common in hypoglycemia of the recurrent hypoglycemia and diabetic overall effect of the vascular. Once you have recurrent hypoglycemia, ultimately they are more prone to the macro and macrovascular complications, particularly I am talking with the cardiovascular complication. The awareness of the hypoglycemia is a clinical assessment. We should take of the proper history, clinical history from the patient, history from the third party of the relative. Blood glucose monitoring is a must. Patient is long standing diabetes, they are having the autonomic dysfunction, autonomic chance of the push hypertension, tachycardia, unawareness to the hypoglycemia symptoms, and some of the validated of the scoring. I am going to this particular the recurrent, how to calculate the hypoglycemia by the recurrent hypoglycemia diabetes. I am talking this particular AI assessment score. The assessment of the AI is a gold score with the clerk of the. I am talking with the what is a gold score? Do you know when the hypo is a connectivity? If the less than 3, less than 4 is a good, but more than 4 is a more chance of the hypoglycemia. And the clock score is the third 8 point of the questionnaire. We should take of the questionnaire, presence of the hypoglycemia symptoms, loss of hypoglycemia symptoms, frequency of the inability to do self-treat, frequency of the severe hypoglycemia 6 months, and any history of the coma, seizures the last years, and where the blood sugar is less than 40 milligram deciliter and lower of the blood sugar symptom. These are some of the 8 of the points of criteria of the clerk. So recurrent hypoglycemia management, how to make management of if the hypoglycemic drugs, particular sulfonylurea, long-acting sulfonylurea can cause the, but now is we are having the very good molecules of the anti hyperglycemic, because of most of the drugs are glucose dependent, blood sugar is high, they are going to the work, hypoglycemia is very less. Avoid and relaxation of the strict glycemic control, particularly elderly, diabetes, long duration of diabetes with autonomic dysfunction. We should take, or we should keep the target HbA1c 7.5 to 8% of the defense eating the policy frequency. We should take 3 major meals, 2 minor meals, and SMBG monitor. CMBG is a must of the psycho-education program of this program. Before going to start with any insulin, you are doing the brittle diabetes, Yeah, we are going to, we should explain what about the hypoglycemia and various insulin analog, continuous subcutaneous infusion, and pancreatic, and these are some of the symptoms of the use of the CGM reduce the hypoglycemia. Who are type 1 diabetes, recurrent hypoglycemia, particular nocturnal hypoglycemia, we are going to enforce the CGM is a must. All the type 1 diabetes, we should put on the CGM, and what about the, that can be prevent and reduce the nocturnal hypoglycemia of the this particular, and instruction and guided education reduce the risk of the hypoglycemia, improve the glycemia, hypoglycemia awareness, type 1 diabetes. All these are small of the defined is a 5 days course for the adult with a type 1 diabetes. We should make before going to start with a basal bolus dose, a pre-mix insulin. We should educate for the 5 days, five days, and we should make how to make up the calculate with the carbohydrate counting with the insulin ratio is a must of this particular. Technologically, policy of the how to make up the policy, better insulin delivery. Now we are having the very good insulin analog of the various insulin pump, CGM plus glucose monitoring, better blood glucose awareness training, educate, pattern is diagnosis of the CGM, and automatic insulin delivery, low blood and closed loop of this particular the recurrent hypoglycemia and diabetic conclusion of the impair the awareness of the hypoglycemia is a key feature of the either type 1 or type 2 diabetes, and this further the impair the associated with the significant increase the risk of the hypoglycemia of the type 1 and type 2 diabetes, and especially evidence of the hypoglycemia use the newer insulin analog rather than pre-mix insulin. Now is a analog and long-acting insulin are is available in the market, and impair the awareness of the hypoglycemia. Thinking took the diabetes therapy. That by the how to make management. Once we are going to diagnose the how to make of the management of hypoglycemia, first we have to take the proper history of the patient. Patient is unconscious and dementia, conjugative decline. We should take history from the patient relative, spouse, diary recorded, validated score, or already I have discussed the previously, blood glucose monitoring data, patient asymptomatically a biochemical hypoglycemia, and correct the hypoglycemia awareness screening program. These are some of the score we should take of the score. Provide the checklist of the screening acute and chronic complication. Diabetes, the patient is having this particular macro and macrovascular complication. Able to red flag of the hypoglycemia. Who are hypoglycemia, put the red flag. They are more prone to the hypoglycemia. They are having the very brittle and fragile diabetes. Novel tool that complement the role of the self-monitoring. We should educate, monitor of the right side. You can see of this particular the feeling of uneasiness, corporal sweating, palpitation, tachycardia, headache, confusion of these are some of the score of the SMBG is a must of all the type 2 diabetes. We should go to the monitoring, educate all the patients. You should take glucometer and take the pre-breakfast, pre-lunch, post-lunch, 4 p.m. and 10 p.m. These are some of the 4 to 5 points of the blood glucose monitoring. Real time of the CGM is a must. What type 1 diabetes, brittle diabetes with the multiple insulin, they should take of the real time CGM, and plus glucometer is a must of the how to prevent the hypoglycemia. Educate. Again, I am going to talk with the educate, diet, exercise, but what about the, they should know what about the carbohydrate counting, glucose monitoring, and medicine of the patient is going to medications adjustment. Patient is having a long gastric sulfonylurea. We should cut the dose of the newer insulin analogs of the is available in all the market. We should use rather than pre-mix insulin, and we should go to this particular. You can see once going to the use the insulin analog has show the lower hypoglycemic rates compared to particular nocturnal hypoglycemia is of the constituency proven the hypoglycemia benefit of the various trials of the begin, switch and devotee trial. More than 16,000 patients were taken with the declude with the large international unit of the 100 unit. You can see of the chance of the hypoglycemia are less compared to the other insulin. The how to treat, one person is coming with the severe hypoglycemia. The rules of the 15 gram of the fast acting carbohydrate is the non-severe hypoglycemia, and up to that 20 gram of the severe hypoglycemia. Patient is coming, if the blood sugar is a 70 milligram, we should give the 15, 15, 15, rules of the 15 of the, either we can give the small piece of fruits, 1.5 cup of the fruit juices, 1 tablespoon sugar, 3 to 5 candies, 4 glucose tablet, and hypotab is available in market is a range of 15 milligram, and after 15 minutes we should recheck the blood sugar. Still if the blood sugar is not achieved that 70, 80, again we can go to the repeat of 15, 15, 15, 15. And again after the 15 minutes, we can check the blood sugar. Again we are not. These are some, if the patient is recurrent hypoglycemia, in spite of this particular, some of the people trials, what about how to use of type 1 diabetes, they should keep on the 1 milligram of the glucagon is a emergency kit. What is, how to make up the policy of the improve the treatment, management, hypoglycemia of the educate, monitor, diet, exercise, individualize the HbA1c. Person is young, we should keep the HbA1c 6.6.5. If the older, elderly with other comorbidity condition, we should keep the HbA1c little bit of the reluctant of the 7.5 to 8% of the improve the pharmacological treatment. Patient is already of the 4 or 6 milligram of the gimipad, we can cut down the dose of the sulfonylurea, can cause the hypoglycemia because it is glucose independent. On monitor, and other technology already we have talked last 2 days of the technology of the day. Thank you. To summarize of the hypoglycemia, especially I am going to severe hypoglycemia, is a effective diabetes management, reduction of the hypoglycemia consecutive of the unmet medical need among the patient with the type 2 diabetes, and insulin initiation. Next generation we should use the insulin of the newer insulin. There is a chance of the hypoglycemia, particularly nocturnal hypoglycemia is very less. Thank you for hearing me.